Welcome, everybody. We're just a minute away from starting tonight's webinar. And I want to thank those of you who are already online here. We've got a nice big audience. Dr. Ihde is excited to present, and we will start in just a minute at the top of the hour. And there we are. Welcome to the fourth EGS webinar, Shaping the Future of GERD Management. My name is Debbie Donovan, and I'm the Senior Director of Corporate Marketing at EGS. I recognize many of the names on both the registration list and who's here today, and it is an honor for me to host today's session. We are fortunate to have Dr. Glenn Ihde with us tonight. Prior to introducing him, I'd like to cover a few event logistics. Dr. Ihde, if you could go forward one slide, please.
Okay.
Great. First, so that we don't hear any background noise, we placed everyone on mute. However, we would like this event to be interactive, and we invite you to ask questions using the question feature in the event control panel. We will answer them at the end of the presentation. Yes, we are recording the session, and we will distribute it in about a week. In addition to your questions, we will also conduct a few polls throughout the presentation. We're going to test this right now, and I'm going to put up the first poll, and that is, who is in the audience tonight? And if you could please just click one of the buttons, that would be very helpful so that we can see who's here. You know, GERD patients are co-managed by GIs and surgeons, and each come with their unique perspective on the disease, diagnosis, and treatment options. So it looks like more people are voting. And it appears that we have a large contingent of general surgeons tonight. I will wait for just a moment more before I close the poll down. All right, I'm going to close this, and I'm going to share the results with everybody. So you can see we have a large number of general surgeons on the line with us tonight, and a nice healthy group of gastroenterologists as well. Okay, so let's get started. Slide 3, please. The next slide is what you need.
All right.
Okay. I'd like to introduce our esteemed presenter, Dr. Glenn Ihde. He is based in San Angelo Medical Center in Texas. Dr. Ihde has the distinction of having performed the most TIF procedures ever, 640 and counting. These are a combination of both straight TIF procedures, concomitant hiatal hernia repairs, and he's revised a fair number of laparoscopic Nissens that have failed in the past. He published the first paper on concomitant procedures in 2011, and in 2015, he published again on hiatal hernia measurement. Those two papers are available as handouts in the control panel that you can download and read. Last year, Dr. Ihde helped Endogastric Solutions submit a special application to the FDA to officially add the esophagus product label, the ability to repair hiatal hernias immediately prior to TIF procedures. And we are very grateful for his involvement in that process. To say Dr. Ihde is enthusiastic about hiatal hernias is really downplaying his passion. He's very obsessed, and in the nerdiest way possible. And I have learned so much from him over the years. So sit back and enjoy this deep dive into hiatal hernia. We're going to talk about history, measurements, repairs, and patient selection. Dr. Ihde, thank you for being with us this evening, and I now turn this event over to you.
Thank you, Debbie. I really appreciate Endogastric Solutions asking me to do this webinar. Like you said, I'm geeky excited about hiatal hernia repairs, and I hope to share all this information so that we're all speaking the same language and we're all working towards the same solutions. So I'll start with a little bit of history, because throughout the history of surgery, we've dealt with hiatal hernias, and it began as really an anatomic repair, meaning they really weren't sure what it was. There was a hole in the diaphragm, and so they fixed it. And Allison published on that, but then they recognized the relationship to reflux, and they began to repair the hiatal hernia alone, and found that maybe 50% of the patients continue to have reflux. So they knew that that wasn't the entire answer. Ron Belzy is the one who's really responsible for identifying the relationship. And he kind of, through a series of operations, was able to show that about 50% of the reflux control has to do with the hiatal repair, and about 50% has to do with the fundoplication. And so although Dr. Nissen is certainly famous for his work, Dr. Belzy is the one who did all the research behind that. And there's a nice little chapter called The History of Surgery for Hiatal Hernia and Gastroesophageal Reflux that I think is very helpful for people to understand sort of where this history came from. And of course, more recent publications talk about the importance of hiatal hernia and the repair of hiatal hernia. If we look at symptoms, especially this left-sided graphic, we see that, you know, as the greatest transverse diameter and hernia size increases, the LAS pressure decreases and the reflux score increases. So it's very clear that the symptoms are related to the size of the hiatal hernia. And on the right side, they also do pressure measurements, and it shows that the presence of a hiatal hernia really affects how much pressure has to be applied across the LES in order to control reflux. So I think we wanted to do, that was the first poll that you did, right, Debbie?
Correct. So why don't you go into the next slide, and we'll take a poll as soon as we get into the next slide. Okay.
So we started looking at doing hiatal hernia or doing transoral fundoplication in 2009, the end of 2009, and there were some endoluminal fundoplication studies that were available. And what we began to realize is people were recognizing that hiatal hernia repair, or at least the presence of a hiatal hernia, really affected the quality of the fundoplication and whether the fundoplication would be effective at controlling reflux. And by the time we started working on this, they hadn't really come to the conclusion of, other than the 2-centimeter axial displacement measurement, you know, what other criteria would be necessary to control reflux. But it's clear that when there is an obvious hiatal hernia present, that your transoral fundoplication is not going to be very effective, and that continues to be seen in other types of fundoplications as well. The other thing that we noted is kind of in the history of reflux surgery that hiatal hernia had a very significant part in the failure after surgery. In other words, people would get a hiatal repair and a Nissen fundoplication, and when they failed, a lot of the ideas surrounding why they failed had to do with displacement of the wrap and movement of the wrap through a hiatal hernia and just a hiatal hernia. So all of that failure data seemed to be centered around whether or not the hiatal hernia was present or not with the fundoplication. And that led us to our study in 2011. And there have been other studies as well that kind of follow that. It's the same experience that they had with Nissen's and the same experience they had with Belzy's. So it's a common thread, and we also saw this happen with gastric banding, and we also saw it with gastric sleeve. So this is what we were looking at. We would do a transoral fundoplication 6 months, do a repeat endoscopy to see, you know, how things were going. And you can see in this picture that there is a good fundoplication here, but it's buried in this large hiatal defect. And so we really had to ask ourselves a couple of questions. The first question being, how did we not see this preoperatively? I mean, if this size of hernia was present preoperatively, we likely would not have done a TIF. We would have done a Nissen at the time. The second question was, you know, maybe I'm not just just not that good at endoscopy. Although I was doing about 20 EGDs a week, I thought, well, maybe I don't understand this very well. The next thing was sort of, well, is there something about creating the fundoplication that now is pressurizing the hiatus and causing what may have been a smaller hiatal laxity to become a hiatal defect? I don't know about that. And then the last thing was, well, maybe we're just not doing the right things to measure a hiatal hernia. So the causes of failure were more important than the causes of our success, and we were worried about diagnosis. We talked about, how much of a wrap should we be doing? Should it be 270 degrees? Should it be 330 degrees? And there have been some studies on that. We moved from a 6.5 millimeter fastener to a 7.5 millimeter fastener because we felt like the shortener fasteners were pulling through, and maybe that was going on. But we came back to this inadequate assessment of the hiatus. So we were trying to assess who would need a hiatal repair and who wouldn't. And we were starting off with endoscopy and the typical comparison of the Z-line position to the diaphragmatic pinch. But we realized when we started looking into this that the axial displacement was actually an upper GI measurement. In other words, it's something that had been developed before endoscopy was real common, and we needed to understand that better. In this period of time as well, people started talking about the Hill criteria. So we were looking at measurements of axial displacement. We started talking about greatest transverse diameter, and we also started talking about Hill criteria, and we had to get familiar with what it was and begin to use it. At the same time, people were saying, well, manometry is becoming more common. We have better catheters. Maybe all we need to do is measure with a manometer, and if there is a hiatal defect identifiable on manometry, then that's when we fix it. And then we were also thinking about, okay, well, this must be a spectrum disease where you have a normal hiatus. It gets a little bit more dilated, and then finally you get prolapse of the cardia and the fundus. And so at what point does that laxity become a hiatal hernia? In other words, what does the term hiatal hernia really mean, and do we recognize what that really is? And then if we're looking at laxity becoming hiatal hernia, well, when does that laxity have to be repaired? So those were all the questions that went through our mind, right in the 2010, 2011 period of time as we were working through publishing our paper. So this
Dr.
was
Ihde?
the paper. Yeah.
Dr. Ihde, I'd like to take this opportunity to ask the team or those in attendance what types of other reflux procedures. So I'd like to do poll number 2. So I'm going to launch poll number 2.
Okay.
And if you could just spend some time and see, we'd like to see who is doing what. You can select more than one answer. So those in our audience, what types of things are you doing? I'm just going to leave this running for just a little longer. There seems to be more people voting. Okay, so I am going to close the poll right now. I'm going to share the results with everybody so that you can see how it turned out. Lots of missing, obviously, because we've got lots of surgeons on board, and we've got a lot of TIF procedure experience here too. So I'm going to hide this, and we're going to go back to Dr. Ihde's. This is like the best, nerdiest thing ever. I love that you figured this out. So tell everybody what this lovely slide is all about.
So this slide is the original paper that was published on upper GI measurements, and they created this system of looking at an A ring and a B ring, because we all know that the GE junction, once it becomes mobile, you can't really by endoscopy tell what is esophagus, what's metaplasia, where does the stomach start. So they began to use this system, and what I noticed as I was reading this paper is the limit of the sensitivity for this upper GI technique is 2 centimeters. In other words, you could have a big hiatal hernia, but if it was less than 2 centimeters axial displacement, they could not identify it on the study. Now, this becomes important because in the instructions for use of the original esophagus device, and during the period of time we were being taught, the IFU was for less than 2 centimeters axial displacement. Nobody really understood where that came from. And as I came across this article, at least my assumption is that as they were developing the device and deciding when it was appropriate to use the device, that this was the basis for that 2 centimeter measurement. Because there didn't seem to be any endoscopic assessment criteria that were assigned in the IFU. But by the time we were doing it, we were all using upper endoscopy to assess the hiatal hernia, and we would withdraw from, the diaphragmatic pinch to the Z line, and that's what we would call the axial displacement. Now, whether that was accurate or not because of metaplasia is a whole other argument. And so about January, I think it was 2010, we had a conference in Dallas, and we were reviewing some of the slides that I've shown you and talking about the hiatal hernia problem. And it was suggested actually by Reg Bell that we may need to start doing hiatal hernia repairs. So I took that to heart, and I went home, and well, I was in Dallas, so that was home. And I started doing hiatal hernia repairs in patients in which I could clearly demonstrate that kind of laxity. And I had done about 24 patients. I probably had done about 20 at that time, and we did a few more TIF onlys. And then we started looking at anybody that had a Hill 3 junction and recommending hiatal repair laparoscopically and then transoral fundoplication. And I explained to the patients that these are really 2 separate procedures. We can do hiatal hernia repairs for any other number of reasons, bands or sleeves or bypass or whatever situation. The fundoplication really is a separate procedure. And that's the way I explained it to the patients. And we were able to get another 24 patients, and 18 of the what we called hybrid at the time, but now they call concomitant techniques, were able to report. And I mean, it really demonstrated pretty significant difference in the outcomes at 6 months. So we began then to kind of change the way we viewed hiatal hernias. In other words, we would define a Hill grade 2 as a laxity because that was kind of the nomenclature that was being used at the time, and then a Hill grade 3 as a hiatal hernia repair. And there really weren't any other criteria, but we did kind of mention this 3 centimeter greatest transverse diameter. And then Dr. Barnes, pretty much at the same time, published a paper talking about 3 centimeters greatest transverse diameter as well. So then we decided to start looking at how do we measure this. And initially, we were retroflexing the scope, spending 2 or 3 minutes insufflating the GE junction so that we got good distension, and then using the diameter of the scope in a picture to act as a measuring device. So we'd say, okay, there's 2 or 3 or 4 or 5 scope diameters at the diaphragmatic pinch, and we know the scope is about centimeter across, so if it's 4 scope diameters, that's 4 centimeters. And then we wanted to be sure that once we adopted this, the outcomes would hopefully improve as we were more accurate in defining who needed a hiatal repair and who didn't. So our decision points were, we're going to use axial displacement, but by itself it's inadequate. It doesn't represent somebody who has a very wide hiatal hernia with very little axial displacement. We were going to repair if it was a larger than a Hill grade 2, or what we understood was a Hill grade 2. or if it was greater than 3 centimeters in greatest transverse diameter, using that comparison technique. And the whole lesson of that was that the hiatal hernia, based on the largest or the greatest transverse diameter, is what the phrase we use, matters more than the axial displacement. So then there were other questions. Okay, what else are we missing? Are we now accurately assessing the patient? Do we use X-ray? Do we just use EGD? Do we use both of them? And then there was always a question hanging around about whether the setting of IV sedation made a difference versus general anesthesia. And in the back of my mind, there was a group of us meeting monthly, and we were talking about this. And it seemed as we were talking about a Hill 2 and a Hill 3 that what I was saying and what they were saying was different. And so I was wondering if there was a variability in the way we were using the Hill grade. And again, whether or not using the endoscope to measure was adequate, or was there some other, for instance, video, photographic, graphic manipulation that we could use, or lasers or something like that. So those of us in the group got together and we started doing a series of investigations. And the way we did that is I had about 50 patients that I had videotaped everything: the preoperative evaluation, the pre-surgery endoscopy, the laparoscopic surgery, and the transoral fundoplication. And then I blinded those. I cut down the videos so that it would be easy to see. And we started looking at things like, is it bigger with IV sedation and is it bigger with general anesthesia? Because you had half the people saying, oh yeah, it's going to be bigger anesthesia, general anesthesia, and half the people saying, no, if they're breathing, it's going to accentuate the hiatal defect, and that's a better measurement. So when we blinded the raters to whether it was IV sedation or general anesthesia, what we found is in 43% of the time, the Hill grade assignment appeared larger when we did it under IV sedation. In other words, this seemed to more fully distend the stomach into the hiatal defect, so it was measurable. Now, some of the times they did find that the cases were larger under general anesthesia than IV sedation, but we felt like this was the more accurate number. 43% of the cases, it was larger under IV sedation. So we decided at that point that all of our assessments would be done under IV sedation. The next thing we looked at was whether or not we all agreed. In other words, if I had 50 videos and a fourth of them were Hill 1, a fourth of them were Hill 2, a fourth of them were Hill 3, and a fourth of them were Hill 4, and we blinded you to them, could you rate those the same as everybody else? And what we found is nobody agreed on anything. Okay, the agreement was poor. It got to fair or moderate, moderate in 29%. But then when we analyzed, okay, if we want to repair Hill 3s and 4s and not Hill 1s and 2s and just see what's the break off, it was only about a 50-50 agreement, which was as good as flipping a coin. So what we realized is what one person's Hill criteria was, let's say Hill 3 criteria, the next person might call that a Hill 2, or they might call it a Hill 4, and there was no rhyme or reason as to which one they would pick. And then the other thing we noticed is, okay, let's say we found a pretty good sized defect on endoscopy, and then we did a pre-laparoscopic endoscopy to be sure that there wasn't any increase in their esophagitis, that things looked the same. And it seemed like they weren't the same, that when we did the endoscopy just before laparoscopic hiatal hernia repair, these hiatal hernias didn't seem as big. And then we would do the surgery and be like, no, this looks pretty big. This looks like it has to be repaired. So we did the same study as we took the videos and we compared them to the IV sedation endoscopies, the videos of surgery to the IV sedation endoscopies, and said, well, is this something you would repair or not repair? And interestingly enough, in 22%, the Hill grade that had been assigned by endoscopy was smaller than the expected Hill grade when we looked at things laparoscopically. And then when we divvied them up into, okay, the decision point is between Hill 2 and Hill 3, how many times do they graded a Hill 2, meaning no repair was needed, but when they looked at it by laparoscopy, they said, oh yes, this absolutely has to be repaired, which is Hill grade 3. And it turned out to be 11%. So I started thinking about that a little bit because, you know, our failure rate was hovering around 20%. And I thought, well, if half the time we're making the wrong judgment on Hiatal repair, then that would account for 50% of our failures. And maybe that's fuzzy math and maybe it's not, but to me, it just seemed like this was a pretty significant finding in that we weren't using the right criteria to determine whether or not to repair the Hiatal defect. And at least if we couldn't agree on what a Hill 2 was and a Hill 3 was, then maybe we should be doing our measurement in some other way. So here's a good example. When you first take a look at this, this looks like a fairly intact, maybe Hill 1 GE junction. But we totally insufflate, so you can see all the rugae were missing. They've been flattened out. And we sort of do this posterior rotation of the scope, and we use the scope a little bit to prod this and say, okay, is that big enough to repair? And it seemed big enough to repair, but I certainly wasn't expecting this when we did the laparoscopy. And what you can see is this fat pad in here is probably what's responsible for the variability, is that patients have a fat pad at the G junction. They actually have one anteriorly, and there's also one posteriorly. And we would find as we did these dissections that these fat pads would sometimes fill this entire defect. And there would be a defect that this is probably 2 or 3 times the size of the esophagus. So it's 2 or 3 times bigger than it should be, but you couldn't see it at all because of this big fat pad. So again, we changed again the way we thought about a hiatal hernia. So looking back, what I realized is, I mean, I thought I knew what a hiatal hernia was. I'd been in practice for about 10 years at the point, and I'd been doing, 20 endoscopies a week for that entire time. But I don't think I really understood what a hiatal hernia was, or when it became, at least when it became significant. So I always show this picture because this is what normal truly is. You have the scope, you see some eversion of the Z line, you have a deep implantation of the end of the esophagus into the wall of the stomach, and the esophagus really is part and parcel of the sidewall, meaning the stomach is really a protrusion of the sidewall of the lesser curve. And so as you feel the fundus, the tension on this greatest transverse diameter, the tension on this circumference is really what I should say, is likely what is pulling closed or keeping closed this G junction. So when you look at Hill's paper, and these are pictures from Hill's paper, even his grade 1 is not really a normal GE junction. You don't see this deep implantation of the GE junction. It is everted at the Z line, and it is tight to the scope, but already some of this length is missing. And I think that this is where Demeester starts talking about shortening of the esophagus, or shortening of the intra-abdominal esophagus, or shortening of the LES length. I think that this is a fairly graphic presentation of the difference between this and that. Now, when we go to grade 2, what we realize is that this is no longer inverted into the stomach. It's everted out, and now the top of the stomach, despite this representation, is more like a Coke bottle, where it's a funnel out rather than an implantation in. And I liken this to the terminal ileum into the cecum, where that valve structure is present in the body in more than one place. And then when we get to grade 3, of course, you see the crura here and the crura here are beginning to separate, and the membrane that holds the esophagus in place, the frontoesophageal ligament, has obviously become loose as this is beginning to have an axial displacement. And of course, this is what we all would recognize as a hiatal hernia. There's displacement of the cardia and displacement of the fundus through the diaphragmatic opening. And so before we had gone through this process, I think this was the only thing that we decided was a hiatal hernia. But as we became more familiar with what we were doing, I think this became a hiatal hernia. And now the question is, well, what's the transition point between this and this? Okay. So then what we began doing is what you began to see in that video is we realized that this scope was 1 centimeter across here, but what about this? What if we use this as a true measurement? Because there was some optical illusion to looking at the level of the diaphragmatic pinch and the angulation that we were at, and all of the other factors. Is it insufflated well enough? Are they breathing? Are they not breathing? Is it IV sedation? Is it general anesthesia? And we thought, well, if we had a measuring tape, that'd be great. But the next best thing would be, we know how big this is when we retroflex it. So we decided if we retroflex the tip of the scope into the esophagus, it would be a 3 centimeter greatest transverse diameter. In other words, if it allows this tip from here to here into the Z line, then it was big enough to repair. And if you were able to pull the entire scope back, it was at least 4 centimeters in greatest transverse diameter. Now, we had a little bit of pushback, I got to tell you, from a lot of gastroenterologists that told me that, you know, they had been trained not to do that. It was dangerous. We were distorting the anatomy. We were creating a hiatal hernia defect, or we would injure the esophagus. But I got to tell you, in all the time doing it, we've never had any problems doing it. And that's obviously not a scientific paper, but for what it's worth, in our experience, we haven't had any trouble. So this is the same video, and you see how we move to the posterior aspect, or the 12 o'clock in TIF parlance, and we don't try to force it in there. We fully distend the stomach, all the rugae are gone, and we roll that scope to the posterior segment, and we try to withdraw it. If it goes easily, then that's where we make our judgment on the measurement.
So Dr. Ihde, I'd like to break in at this moment and ask our last poll question, if you don't mind. So the last poll question we have is, what kind of procedure do we have within the audience today? So if you could please take a moment and answer the question. There'll be one answer for this set of question, or this question. And while we're waiting for that to happen, while the voting is going on, I'd like to remind you to please use the question area. We've already got a couple of questions that have come in, but we are getting close to the end, actually, of the formal part of this event. And I want to make sure that anyone who has questions will have a chance to get them answered. So I've been answering a couple things as I see them, but we will get to them. All right, so with that, I think we have a good number of people who have responded. So I'm going to close the poll, share the results. And it looks like we have a nice mix of people who have not performed the procedure yet, and those that have performed it but a while ago, and those that are regularly doing it. So really mix of folks on today's event. So let me hide this. Dr. Ihde, if you could go back into your next slide, that would be awesome.
Okay. So at the beginning, I talked a little bit about how this information may influence outcomes and whether it really did influence outcomes. And it's a little bit hard to get there, but one of the things I noticed when they came out with some of their prospective studies with crossover and sham were that the percentage of people getting off of PPI and the percentage of people having healed esophagitis jumped pretty significantly. And so we have to remember that the TIF registry started in 2010, 2011, I believe. And Tempo and Respect was just recently published in the last year or two. So, you know, has this information, and as we've participated in the various conferences and discussions and training sessions, has it made a difference? And I think it has. I think that these studies are done in TIF-only patients, and so there's both experience in doing the procedure and working the device, and certainly the device has undergone improvements. We went from 6.5 millimeter fasteners to 7.5 millimeter fasteners. But I think selection is a big, big part of it. And so when you see this kind of change, I think that perhaps that demonstrates that we are getting better. So certainly, I think people that were trained in the past and had these kinds of outcomes were still not convinced that this was the procedure to do. In other words, yeah, it works, but sort of. And sort of what we've done since then is say, okay, well, what are the issues involved in these numbers? And when you start looking at these numbers, you start to begin to say, hey, we're getting pretty close to Nissen type numbers. Now, the thing that I think is still missing is pH numbers, and that's something I'm sure that we're going to be reporting on and studying in the future, and I certainly look forward to that. But obviously, I take credit for all this change. So I wanted to give you a demonstration of kind of one of the patients that we worked through the entire process. And so this is about a 3-minute video. This is the initial endoscopy evaluation under IV sedation of this patient. What you'll notice is we had it pretty distended, but they immediately vented all the air. And now you can see all the rugae, but also how large the hiatal defect is, even the stomach rolling into the chest with each breath. And so we were pretty convinced that this patient needed a hiatal repair in addition to the transoral fundoplication. Now the next video is going to, well, let me finish up with this. Watch this as she relaxes a little bit, and as we move the scope, how normal this becomes. And so this was part of the problem of what we were assessing is, are we catching it at the right time? Does it have to do with breathing? Does it have to do with technique? Why is it that, you know, we're not finding these as commonly? And then this was her immediate pre-laparoscopic endoscopy. And again, we're sort of taking the time to distend the rugae, and then we do this retroflex maneuver. But we cannot really get the tip very far into this. Now, I would say maybe 3 centimeters greatest transverse diameter, but certainly not what we had seen in the first video. So then here is the laparoscopic view, and you can see that this is 2 to 3 times the esophageal diameter when you take down basically the peritoneum and the frontoesophageal ligament. And I again, don't believe that the frontoesophageal ligament adds anything once it's been stretched out and really destroyed by whatever process is causing this. But I do a posterior repair as was demonstrated in the Lotus trial, but I also do one anterior stitch. And the reason is because all of the normal anatomic studies that tell us what normal is say that this crural column should cover this central tendon and meet up with this right crural. Now this was done with a bougie, so there's a little bit of gapping in there. We're demonstrating the vagus. I think that I probably put one more stitch in there before deciding to go to endoscopy. So this is the endoscopy immediately after laparoscopic hiatal repair. And as you can see, there's some laxity to the tissue there, but we could not enter the scope even as much as we did with the general anesthesia endoscopy. So this is obviously speeded up. We're doing our transoral fundoplication using the Esophax 2 device. You can see that there is plenty of tissue for the fundoplication. We're using the rotational technique. I'm not sure it's demonstrated real well in this video, but we'll go to the back side and rotate this tissue back to the 12 o'clock position. It's sort of edited out of this. Place our fasteners. The corners, I think, are more important than anything else. I put the 2 corners in first, and then I'll lift this and fill this in. And for the sake of time, that was all edited out, but you can see there's a fastener there. And we get this nice, fluffy, long, well-completed rotational fundoplication. And so that's basically the current technique. So my recommendations. First is, if you're going to do the transoral fundoplication, or at least make a judgment on hiatal repair, do your own endoscopy and do it under IV sedation, because I'm still not convinced that the language that we are using is universal. In other words, I'm not sure that the Hill criteria have been fully adopted. I certainly don't see it in the endoscopies that are sent to me. And so my Hill 3 may be different than your Hill 3. The second thing is really insufflate the stomach. And I put in this little trick. If you use a little cricoid pressure while the patient is breathing on their own, they may be venting some of your insufflation spontaneously, and you may never be able to fully inflate the stomach without cricoid pressure. The next thing is regurgitation as a symptom really biases my evaluation. I think that it's highly suspicious for a hiatal hernia when people come to me and they say, you have heartburn, but the thing that really keeps me up at night is regurgitation that comes up in the middle of the night and I start choking. If you retroflex the tip of the scope and you're able to enter the hiatus, then it's 3 centimeters and larger if you're able to get the full omega loop in. So I really have had no injuries in the 640 procedures that I've done. Does that mean it's safe? Well, I think you'll have to judge that, and it's endoscopy in your hands, and you know, you do what you think you should do. Maybe you should do the retroflex view and just compare it to the scope diameter, but I think this is safe, and that's what I do. Again, if you don't use a Hill grade, start using it. You may see that your values change as you start using it and you compare it to what you see when you do the transoral fundoplication. It may change as you do laparoscopic surgery. You may evaluate the hiatus when you're doing other procedures. Let's say you're going to do a lap chole and you do a symptom survey on the patient, say, oh, you know, what are your symptoms? And then look at the laparoscopic view and see if those two things are lining up or not. And again, if regurgitation is a symptom and you're not sure whether there should be a hiatal repair or not, I would bias my evaluation towards the hiatal repair. If your endoscopy is sort of like, it looks like a Hill 2, but, you know, they have regurgitation, you know, it's probably a hiatal hernia that needs to be repaired. So I think our studies demonstrated that endoscopy undervalues the size of the hiatus, and so you want to bias towards a larger hiatus. Also, I think that history has taught us to suspect hiatal failure in all recurrences. In other words, is it the hiatal hernia repair or is it the fundoplication? And my experience is that it's always the hiatal hernia repair. It's not until they've had a recurrent hiatal hernia for a long period of time and that fundoplication, particularly a transoral fundoplication, is moving in and out of that G junction with every breath that it starts pulling the fundoplication apart. The other thing that I've noticed is in patients that come back to me because they've had recurrent symptoms and I do an evaluation and they do have a hiatal hernia, I will stop and talk to them about how did this happen? When did your symptoms occur? And almost to every patient, they will recall a lifting event. I have a teacher that moved her apartment. I have an older lady that didn't think she had lifted anything, but her friend came to the appointment and said, no, you do a lot of gardening, you're lifting a lot of bags of topsoil, that certainly could have added to it. I had a guy just a week ago that remodeled his attic, and as soon as he finished that day of work, he had recurrent symptoms, and sure enough, a recurrent hiatal hernia. I have two gentlemen that began lifting weights because, you know, they wanted to become fit again. And it was, you know, not too long after they started doing bench presses and those sorts of things, leg lifts, that, you know, they came back with symptoms. And I think the lesson is that the abdominal cavity is a pressurized system when you're lifting or pushing or pulling or straining, and it's going to fail at its weak point, and the weak point is the various hernia spots, and certainly the hiatus is one of them. So those are my recommendations. I think, again, that we've done a very good job of controlling symptoms, but it's this improvement in the cessation of PPIs and the healing of esophagitis. I think that our improved assessment of the hiatus has probably caused our very experienced TIF proceduralists to become better at selecting the patients that will do well with TIF only. And Testoni did a nice job of elucidating some of these differences. In other words, he repeated our assessment of Hill grade 2 and Hill grade 3 as being the breakoff point, the 2 centimeter greatest transverse diameter as being a breakoff point. The number of fasteners was certainly a very important part of his study, showing that, you know, the cartridge has got 20 fasteners. And every time I do it, I think of it, the comment had been made back in that Dallas conference that to think about it like spot welding. The more spot welds you have, the stronger your weld is. So certainly I try to use all of the fasteners every time. It's rare that I go to a second cartridge, but if I'm not satisfied with the way it looks, then I will go to a second cartridge. But you also have to remember the enemy of good is better. And if you poke the esophagus too many times, it just might have a problem. Also, this rotational technique, again, I think Reg Bell was the guy that said, hey, maybe we should be rotating around like we do in Nissen instead of just pulling up the 6 o'clock, 5, 6, and 7 o'clock position. And I think very clearly that adds to the improvement. So all of those things, I think, are factors that feed into it. There is actually a prospective study that was done by Janu and Mavrelis, two very experienced participants in both hiatal repair and transoral fundoplication, and they show very nice improvement in the symptoms both at 6 months and at 12 months, which leads us to our next study, which was the 5-year study. Now, the 5-year study was not as impressive as some of these in terms of numbers, but you have to remember that 5 years ago, when they started, probably really 7 years ago, when they started collecting this data, a lot of this selection criteria for hiatal hernia was not in place. And it may be that that's one of the reasons why that data is not as stellar as we'd like to see it. Although, frankly, I think it does demonstrate pretty good endurance. Because if you look at other studies of hiatal repair and breakdown, especially Olschlager's 5-year study, it's clear that hiatal hernia repair and getting it to remain repaired and not break down is really the bane of reflux surgery. Nobody has come up with a better solution for that. I do think the posterior repair technique is superior, but I do add that anterior stitch because I want the anatomy to be back in place where it's supposed to be. I don't know how many of you guys still use mesh, but I think mesh has come and gone, especially as well as Olschlager did that study. I think you just have to believe that it's not really helping. I don't think it's necessarily hurting unless it erodes, but I don't think it's helping at all. And then finally, just kind of a review of where we are in experience. What's nice about Endogastric Solutions is they said, we have this device and we have a procedure that the device can do. We want to put it in your hands and see how you do. And their breadth of information, I think, is remarkable. The second is, you know, sometimes when a device comes out or even a medicine comes out, and you're doing limited studies to get through the FDA process, but then you put it out into the general population, you find, you know, some warts, right? Some ugly things. I don't think necessarily that has happened at all with this procedure. I think it's gotten better with time, not worse with time. I don't think that we've had any significant difficulties, and certainly the device has become much nicer, avoiding some of the things that people were concerned with, like past pointing of the stylets. I do think that it's shown to be highly effective in controlling subjective symptoms. Objective measurements is something I think we need a little bit more of. But, you know, I think the data at this point is very, very good. And one of the other things is that I think it's very safe. You compare this to Nissen serious adverse event rates, this is much better. And frankly, the reason why I quit doing laparoscopic Nissens, and I was a victim of this because I came out of residence in 1998 as a fully trained advanced laparoscopic surgeon ready to do lap Nissens. That was going to be my career. And that was the year that Nissens took a nosedive. Nobody was referring Nissens, and that's because of all the side effects, the bloating, the dysphagia, the gassiness, what we call the Nissen bloating syndrome. One of the reasons I started doing this procedure was the initial paper showing that none of that was happening. And I think even in, I think it was the registry, there was a negative correlation, meaning people with bloating and gassiness actually improved rather than got worse. And that's really the reason why we stopped doing surgical repairs for reflux disease. Medicines came out at the same period of time. They at least controlled the symptoms. They may not be controlling the reflux, but they were controlling the symptoms. And that was good enough at that time to say, well, we shouldn't be subjecting people to a procedure that has so many side effects that we don't have a solution to. And when transoral fundoplication came around, it solved that problem. And people ask me, why do I do the laparoscopic hiatal repair and not just go ahead and do the Nissen? That's the very reason. Because I recognize that the reason we quit doing Nissens wasn't that it was not effective. It's very effective. It's that the side effect profile was too much for the public to tolerate. Okay, so that's the end of my presentation.
Thanks, Dr. Ihde. We do have quite a few questions here, so let's see if we can start answering these one at a time. First of all, Dr. Barnes loves your trick about curling, doing the retroflex. He's been saying, it's amazing. What a great trick. So just a little compliment from Dr. Barnes, who also has a very heavy, large number of patients that he's done in the past. So
Absolutely.
The other one, yeah. So Dr. Shaw asked, what is your post-op routine for patients, and are all the patients done in the OR and endoscopy suite? And then he also asked something about the last part being about for straight TIF, but I think you've covered that. So let's just hone in on what is your post-op routine for patients, and are all the patients done in the OR or endoscopy suite? So
that's a great question, because I think the post-op routine is really important, especially for recognizing when you have a problem. So let's start with the OR and endoscopy suite. When I started, I would do both. If it was a TIF only, I'd do it in the endoscopy suite. We did it under general anesthesia. We placed people in left lower decubitus position. And I do believe that you need general anesthesia to do this. So the hospital I was in at that time was very accommodating for that. And of course, if we do the Hiatal repair, that's done in the OR. And I also preserve the sterile field. In other words, I'll put a towel down, then a 3/4 sheet, and I'll fold the sheets over and maintain that sterile field and the equipment in place. So if I go in by endoscopy before I do the TIF, and I see anything possibly wrong, I can immediately go back in and repair it laparoscopically. And frankly, that's where the Nissen fundoplication was developed, right? It was an ulceration through the wall of the esophagus, and the fundoplication was just a patch to patch the repair. I think it's important to think about it in that way. Now, in terms of postoperative care, I keep people overnight one night. I check lab work in the morning. I start them on a clear liquid diet immediately, and to be sure that they have tolerated that the next morning. And then my criteria for discharge is no tachycardia, no heart rate more than 100. If they came into the office and they were mildly tachycardic, let's say 102 or 103, you know, I'd say 105 would be the criteria. But tachycardia is a very sensitive indicator that you have mediastinitis occurring. And then the second criteria is a white count greater than 15. So a lot of the patients will have a mild increase in the white count, 11, 12, 13, 14. And that has to do, I think, with injury to the mucosa of the stomach. So, and the way I came to this is, you know, every once in a while when we're trying to milk up that fundoplication, we'll scrape the mucosa of the stomach and leave kind of a wound there. And the next day, the white count would be 18,000. So I think that in those cases, I always, if the heart rate is up and if there is an elevated white count, then I always keep them another night. I put them immediately on IV antibiotics. And I get either a gastrograph and upper GI study or a gastrograph and contrast CT. The reason I do CT is if I don't believe the upper GI, the CT volume is 300 cc's. It's 10 times the upper GI volume, which is 30 cc's or maybe 60 cc's in most facilities. And I think that extra volume challenge is helpful in demonstrating whether or not there's a leak. The leaks are very, very rare. I've had 3 in 640 procedures. And, you know, I found them all early and I fixed them. But, you know, that's the thing that you fear, right, is a leak. When they go home then, let's say their white count gets better the next day, their tachycardia is resolved. I will tell you, if you do the CT, you will find air in the mediastinum every single time. And that really doesn't mean anything. What you need to do is find whether or not there's contrast in the mediastinum. But let's say their white count gets better, they're on the IV antibiotics, they go home. What I do is I put them on a lifting restriction, no more than 10 or 15 pounds for the first 2 weeks, no more than 20 or 25 pounds until they're 8 weeks post-op, and no more than 50 pounds long-term. Now, whether they're going to follow that 50-pound rule or not, I don't know, but at least I said it. The second thing is the diet progression. I do 2 weeks of a full liquid diet. So clear liquid only the day of surgery, full liquids for 2 weeks, then pureed for a week, which is like baby food, and then soft food for a week, meaning if you can smash it with a fork, they can eat it, and then nothing to chew until they get to 6 weeks. And the reason I do this is because of esophageal spasm. For people that do not follow that diet, I don't find that they ruin the repair. What I find is they have esophageal spasm, and sometimes it's pretty severe, and sometimes it lasts for a while. So if I have somebody that's really sore, I'll use a GI cocktail with Donatol if you can still get it. There was a shortage for a while, but you can get it still, I think. And the reason I think they get esophageal spasm is because the esophagus is a muscle, and like any other muscle, if it's not working against a force, exercising, if you will, then I think it atrophies and gets weak. So if your LES pressure is 0 or 3 or 10, and the next day it's 40 or 50, I don't believe that that muscle has either the strength or the coordination to move things downstream. And so I think of the 6-week diet as a rehab program for the esophagus. So the liquids will go down by gravity, but they will stimulate a contraction, and usually a coordinated contraction. So then if they move to pureed foods and they start having esophageal spasm, I'll back them up to full liquids again for another week before they go back. I find that patients that don't follow that and start having esophageal spasm but continue to eat solid food will really create a problem for themselves. They will have a long-lasting and fairly severe chest pain that I think is, again, esophageal spasm. And I've even done manometry on some of these patients, and they have a pretty aggressive contraction in mid or distal esophagus that does not relieve itself. So again, there's just a couple of those patients out there, but I think that rehab for the esophagus is the reason that we have that diet. The other thing that I'll add is a lot of patients will have that left-sided shoulder pain, and that comes from the phrenic nerve, the 3-4-5, C3-4-5 innervation. And for many years, that was the bane of my existence with TIF, because we would have people just really moaning and wailing about it. And I tried muscle relaxants, I tried Neurontin, I tried narcotics, I tried a lot of different things. And what I found is a compounded medication that has nifedipine and lidocaine and some other little things in it that has really resolved that problem completely. There's a compounded medicine, so it costs something, but a lot of the insurances will cover it. Medicare won't, but it's resolved that problem completely. And if you guys want a copy of that, I'll provide it to Debbie and she can get it to me.
Great. Dr. Ihde, we do have another question. Part of it, I think, has been answered, but Dr. Doshman had two things. One is, does everybody deserve manometry? And I know you touched on manometry just a second ago, but he also wanted to know, with the Esophax Z, do you think 20 fasteners is enough? With the Esophax 2 device, getting 20 was difficult, but with the Z device, it's much easier, but is more better. Before you answer that, what I do want to do, Dr. Doshman, is ask you to go and look at the new paper from Dr. Trad, and it's the 5-year data from Tempo. And what you'll see in there is that all Tempo patients had 21 fasteners plus or minus 4. So even at the time that we were starting to do the Tempo enrollment, which happened very quickly, the very short enrollment period, there was a sense that more fasteners were better. And I know that I've heard that a lot. So Dr. Ihde, can you comment on that about more fasteners and its ease now that you have the Z Plus device? And then manometry, comment on manometry.
Fill up with manometry. When I first started, I didn't have manometry and I used upper GI, and that was probably not adequate enough. Does everybody need manometry? Absolutely. I'm not really sold on that. I do think manometry is very, very helpful, though, especially when you have patients that have problems with the esophageal spasm and you're thinking, oh my gosh, what have I done? I think having that pre-op manometry is very helpful in kind of identifying those patients. The achalasia patients are really rare. And so I find the argument that you should do a manometry on everybody because you're looking for achalasia, it's kind of a stretch. But on the other hand, I've started doing manometry on almost everybody. Now, if a patient won't tolerate manometry, will I still do their hiatal hernia TIF? Yeah, so long as there isn't anything else. I might go ahead and do the upper GI and just make sure they don't have a bird's beak. But I think it's safe to do the hiatal repair and TIF or TIF alone. With the Esophax Z, so I haven't started using the Esophax Z because my hospital didn't want to use a pediatric or invest in the pediatric scope that it would need. But now that the Z Plus is out, and it has an HD scope, I'm going to start using it. I do think 20 fasteners has been enough. I mean, in all the Esophax 2 devices, I think the 20 fasteners have done a good job. I've gotten good fundoplications. I always feel like I can get rotated almost all the way around. It's not that there are patients that you could get more fasteners in, but again, sort of the enemy of good is better. And I think if we look at the current data, that 20 is a good number.
Okay. So with that, there is a couple of other questions that have come in. One is, was the pre-TIF endoscopy done by a GI, or I think you mentioned that you do your own endoscopies prior.
So one of the
because of that issue related to not everyone defines the Hill grades the same way you do, right?
Exactly. So one of the reasons I started doing my own endoscopy is, I wanted to get along with everybody. I wanted to work with my gastroenterologist, but they would say, oh, this is a great TIF patient. And I would start doing the TIF, and I'd say, well, this hiatus is pretty big. And in my experience, this patient will have a failure. So then, not to step on any toes, but I started doing my own endoscopy to be sure that what they were describing is what I was seeing. And then when I did the comparison paper, I was like, okay, I'm going to have to go do my own endoscopy. So I think part of the problem is we're not all using the same language, and we're not all using the same measurement device or the same measurement technique. So I think that if your surgeon and your gastroenterologist get together, they review this stuff, they say, yeah, we're going to use this technique, and we're going to agree on this language, and this hill is this, and 3 centimeters is our basis for repair if we use a retroflex scope as a measuring device. I think if you come to that agreement, then I think it's great to have your gastroenterologist do it. Because to me, it's just putting the patient through another procedure, that really they shouldn't need a repeat. But just because of, my experience, I started doing it. So that's where I was.
Okay. Because it's 7 minutes after the top of the hour, I would like to just squeeze in one little question here. I wonder, someone asked, I wonder what he considers non-compliant patients and what leads to some of the fasteners coming down to 11 or 1. Do you have any theories about why you think some of the wrap comes apart at 11 and 1 over time? Anything you've seen?
Well, I think you have to think about the wrap moving through the GE or through the hiatus. I think that that's the mechanism by which those fasteners come out. The other thing that I will bias myself towards is soda. I tell my patients not to drink any soda after these procedures because I think that the angle becomes wider at the angle of His when the fundus is fully distended. And the amount of carbonation in sodas will more than over distend, the fundus. So for instance, when you're doing your transoral fundoplication, you're doing your TIF, and you overfill the stomach, you see the tension that it puts on, especially that 1 o'clock set of fasteners. And in my mind, the same thing is doing when the patient is drinking sodas. And I think that a big part of the failure of the fundoplication by itself is due to the drinking of soda.
Okay. One last question from Dr. Fanous. He has kind of a series of questions here. Do you use pre-op steroids?
Yes.
With a more aggressive, yes, okay, good. With a more aggressive wrap, is it likely that you are injuring the vagus? And sort of with that is, how do you measure the length of the wrap? Or I guess
there
you go.
When we talk to some of the others that have done a lot of work in this, we all agree that the vagus is right against the spine, and it's unlikely that you're going to get your wrap all the way back there and injure it. And one of the things I do as a workup is I always try to get the patients to do gastric emptying study, because you want to know if they come back and say, yeah, I'm having a lot of bloating, Did they have preoperative gastroparesis? Because 20% of the reflux population does. And then did the gastroparesis get worse or did it get better after I did my hiatal repair and TIF? And so those patients that I followed up with a repeat gastric emptying study do not have worsened numbers on the gastric emptying study. So I don't have any evidence that we've injured the esophagus in these cases. I measured the length of the wrap really using the esophagus device because each of those links is a centimeter in length. You can retroflex the scope and try to do a withdrawal, but I'm not sure that that's very accurate. So I think that, you know, just before you get out or remove the device, if you use the tissue mold as kind of a measurement, you can tell whether you have a good long wrap or not. I think if it's just a nubbin wrap, it's just a centimeter, then likely that patient's not going to do real well. I do think the length matters. It should be at least 2 to 3 centimeters, and it's great if you can get a 4 centimeter wrap.
Great. Well, with that, I think we have answered all the questions that have come in. Thank you, everyone, for participating tonight.
Thank you so much that took time to listen.
We are definitely going to need that that post-op compound medication that you're suggesting, Dr. Ihde. So I will make sure to send from you, and then we will distribute the recording to everyone who registered for today's event. And again, keep an eye out for the next webinar that we have. And thank you, everyone, so much for joining us this evening.
Thank you.